safe.
Oh, what is that?
Well, obviously nothing, and nobody's saying.
It's like the mic unplugged itself. No, she can't talk anymore. Take the mic away.
Yeah, that is for a good reason. That's mine? No, that's not mine. Where's mine? Damn it, where's mine?
It's.
Oh, yeah.
Are you kidding me? Did you see that?
No, I was paying
Is
attention.
this my phone? Where's my phone? Damn it. It's on. Ready?
Okay,
It's been a
let's
long
go.
day.
Hi guys, thanks for joining. This is Essence of Medicine. Today we're going to be talking about why your spine surgeon wants you to lose weight. I'm Amanda Armagast.
Dominic Moore.
And I'm Dr. Abbasi for Essence.
So this is actually a really common topic that we see almost every day when we have clinic, correct? Is patients coming in saying that their spine surgeon told them to lose weight. The thing is with us, we actually do not tell our patients that they need to lose weight. So I want to identify the difference between why some spine surgeons don't require weight loss, whereas other surgeons will say you need to lose 100 pounds, otherwise I can't touch you.
To differentiate that, we do say to the patient, lose weight in a healthy way, but that's not a requirement for surgery.
Mhm.
And we know that frankly, obesity is an epidemic, especially in the United States. We have the highest level of obesity in the entire world, I would say, except few group of people, we have the highest level of obesity.
But
Dominic, do you know who they are?
Mm-mm.
Who has the highest level of obesity?
I think I
in the
know.
world? Go.
Oh.
Sumo.
Yes.
Oh,
Yes.
Surprised you didn't guess that right away.
We talk about obesity in America, and I
Yeah.
immediately start thinking about like the childhood obesity statistics. So
You think of obesity by like lifestyle or diet or things like that, or sumo wrestlers is obese by choice, right?
Yeah,
they want to gain weight because
And yes, sumo wrestler as well, but there's a group of folk, for some folks, some ethnicities that have, it is unbelievably high BMI.
Did
know
you
who
think
they
I
are?
said Samoan?
Yeah.
Oh,
I thought that this.
Oh.
no,
So you were
sumo.
wrong. High five. No, being wrong and right at the same time.
It's my
Samoan.
thing. Yeah, it's my
Yes.
thing. Yeah, Samoan too is something that came to my head, but I didn't want to.
And sumo wrestler, but Samoan has the highest rate of obesity and the worst obesity, and as well many of the natives, they have much higher rate of obesity, like or Inuits or lots of some folks that they have lived for millennia a natural way of life, and all of a sudden we throw them a chocolate that has 2,000 calories.
And they're more likely to hold on to fats and lipids than other ethnics.
Because for millennia, they had to hold off any little bit of a calorie because they might not be able to eat for a whole month. Like one of the things when I was a child, I was watching a documentary that really impressed me, that this little, we would used to call them Eskimos or Inuits now, that they get the blubber of a whale, and they just take the blubber and then start like a candy eating that blubber. And believe it or not, it's not that unhealthy if you live that way of life. But imagine, it's not that you go and get a whale now once every 3 months, but now there's a supermarket that you have access to thousands and thousands of calories. Their metabolism is not made for that. They want to hold on in that cold winter. They want to hold on every little bit of a calorie, and they do that.
You know, that makes sense too, because I remember when I was in school hearing some statistics about foreign countries when they adopt certain Western diets, like they just hyperlipidemia and hypertension, all these things just skyrocketing, metabolic disorders, because their cheeseburger not on the menu over there as often as it was.
Right.
Yeah, that you cannot get a 1,300 calorie happy meal or whatever, and gulp it in. But we are talking about essence of medicine. Let's talk about the background of obesity before we talk about the spine relationship.
Sure.
I won't be long.
This is actually a brief podcast.
Yeah. So for a very long time, half of the population would starve. As a matter of fact, what we call type 2 diabetes is not a disease, it's a survival mechanism. Like in most of the Africa, you see that there's obesity and diabetes is high. In African American, obesity is much higher. Now imagine, how do we treat type 2 diabetes? We reduce the calories. We put them on a diet. The type 2 diabetes completely goes away. Type 2 diabetes is telling your body there's sugar, there are things available, energy available, store it. Okay? And make the insulin less effective, because insulin takes that sugar, put it in your blood, or literally takes it away from your blood. Meaning that if you are already on a low calorie diet and you don't have enough glucose, your brain doesn't work, and then you get eaten. So it's a coping mechanism. Type 2 diabetes is a coping mechanism for you to store as much calories as you can and have higher sugar even with low energy level. Now, all of a sudden, you take those episodes that you cannot eat, or that you take that low calorie diet away, all of a sudden something that usually is an advantage become a disadvantage. And then you have this high the BMI people that have to live with the consequences of that it wasn't there before. Now, what are those consequences? General and on the spine side. Dominic, what do you think? First of all, BMI is body mass index. And what is it? 26, 27 is normal. Then you become overweight. And then after 30, you become obese. After 35, you become severely obese.
Yes.
There's a calculation there that goes into that and so on. But on the general side, on the first and then on the second spine side, why don't we let Amanda, why is obesity bad, Amanda?
Oh, well, it's really bad it's hard on your body because it's a lot to carry around on your tiny little feet. It's hard
all the joints,
on your joints,
including spine.
It's hard on your blood vessels.
Well, the obesity, we know when
your arteries get clogged, it's just harder on your body. It's a lot of process, and it's a lot of things to manage for such a small skeleton, I think.
Yeah. That's actually a pretty good description.
Yeah.
From Lynn.
Yeah, that's pretty good. When you take out if let's say we had an obese person, they weren't at risk for, hyperlipidemia, diabetes, or any of these things that
those are additional general things.
Yeah. If they happen to be clean slate, all they had was obesity, they still have all that extra weight working on their skeletal system. The first place body puts fat is all these visceral organs, packing it in even tighter, so you get all these other things. Like, in fact, people with obesity can get more frequent dietary issues like constipation and whatnot. It's just where you put it first.
Isn't it hard on your heart too?
Oh, incredibly so. And your lungs too. Imagine shifting all that weight at night.
And the lungs, isn't that part of the reason why it's harder to have surgery if you're obese?
Well,
because you're laying.
Actually, that is a very good observation. Now, obviously, the way a person breathes is by what we call negative pressure ventilation, meaning we increase the volume of the chest and we suck the air in. And that is over billions of years, or almost 600 million years. Every living being that has a lung is based on, actually not that long, it's just 400 million years that we have lungs, but it's beside that. But so for all these millions of years, we are built that we suck air in, and now in the last 200 years we've learned a method to push the air in. We tolerate it to a certain point, but at a certain point we have what we call barotrauma of the lung. Because we are not sucking air in, but we are pushing the air in, and exactly punching the lung and the lung tissue. And especially if you're heavy, you're laying. Even worse, in the spine surgery, most of the time the patient lays on their chest, the whole weight. And imagine when you're breathing, your lung get bigger, your chest get bigger and smaller. Now you have to weight all your weight on your lung. Now, for that reason, we know the longer surgery is more risky. As a matter of fact, every surgery, every additional half an hour on the anesthesia adds 17% to the combined risk of the surgery. And
What
now,
does that mean when you say it adds 17% to the combined risk?
okay, let's say that I'm just pulling these numbers out of thin air. You make a surgery on 100,000 people. From that 100,000 people, let's say, let's say 100 of them have a complication.
Okay.
Okay.
Mm-hmm.
That is very low. Yeah, 0.1%, very low.
Mm-hmm.
Most of the time it's much higher. Let's say, actually, let's be realistic. Let's say 1,000 of them from 100,000 people, 1,000 people, that's way more realistic and even higher. 1,000 of them have a complication, let's say pneumonia. Okay. If you do the same surgery and it takes half an hour longer, 1,170 patients will have that complication.
Okay.
So every additional half an hour adds 17% to the combined risk of the surgery. And if you add another half an hour, it's not another 170 people. It is 17% of, not of 1,000, but 17% of 1,170. And so on and so forth. So now you make a surgery instead of 1 hour, 7 hours. You see like a compound interest. That study is based on everybody, even people who lay on their back. As a matter of fact, in that study, most of people were laying on their back. If you just calculate it for people who are on the chest, that number is probably much higher. Prone has higher rate of complication. So now, on that, all of a sudden makes sense that that if you have a very long surgery, it's in every surgery is risk versus benefit. And now, if you have a very long surgery, this is complex surgery, and these patients are with higher BMI, lay longer on their chest, it's much more trauma to their lung. It's much harder for them to recover from the surgery.
Okay.
But that's not just it. In most of the spine surgery, you have to expose the spine, and spine is unfortunately in the middle of your body. Now imagine in a bigger patient, you need to have a longer path to get there. We have a nice study. If you are interested, just Google Abbasi, my name, ABBASI, OLLIF, for oblique lateral posterior lumbar interbody fusion, NIH for National Institute of Health, and BMI, body mass index. Just put those things, you see a paper that we publish is accessible to everybody. You don't have to pay $150 to download it.
It's ridiculous.
It is ridiculous.
Yeah.
You're just trying to learn, and now all of a sudden you have to pay.
But that is how this medical journal works. Okay, so, but this paper is accessible. We publish in a way that's accessible to everybody. And believe me, you understand that. If you just read it, you will understand that there's a chart there. As a matter of fact, I'm wondering if you should, even show that chart, because I think it's important for people to see. Yeah. So what we showed that, obviously it makes sense. In a regular surgery, when the BMI goes up, the time of the surgery goes up. Exactly. Wow, you're fast.
Yeah, I know you yelled at me for this the other day. I do stuff a lot more simply sometimes.
Honestly,
You really only have to type in OLLIF BMI.
Wow. And it comes up right away, huh?
Well, aren't you impressive?
Thank you. Thank you. It's not my first day here.
Okay. So this shows actually.
Do you know how to get just a photo?
Right click on
I
it
think
again.
we see that. I think we see that. If you want to just leave it there, that's fine.
Okay.
So what you see there, a blue line. That blue line, now, first of all, every chart has two axes, or this kind of chart have two axes. On the x-axis, on the bottom, you see the BMI, body mass index. Obviously, higher BMI, bigger patient. On the y-axis, you see time of the surgery. These are about 400 patients, all the spinal fusion in one hospital, 1 year. And as you see, when the BMI goes up, the time on the anesthesia goes up, and all other complications correlate with that. But it makes sense that if you have to go through more tissue in a regular surgery, it takes longer.
Mhm.
And we just talked about more time on the anesthesia, more risk associated with the surgery. That becomes at certain point that risk of the surgery are not justified for that surgery. As a matter of fact, most of our societies now recommend not to do elective fusions for a patient with a BMI of 40 and above. That it really excluded lots of miserable people.
What about like Dwayne "The Rock" Johnson?
Yeah,
Because
that is, some people are just big because they have lots of bone density and so on. There is
And
some
muscle.
personal evaluation there involved in that as well. Certainly always is, okay?
I guess, well, my question is, if you're
Personal
somebody
judgment.
who has like a high BMI because you have a lot of muscle, like Dwayne "The Rock" Johnson is a huge guy, but he's not fat.
Yeah, but we still have to work through a lot of tissue to
Yeah,
get
that's
there.
that was my question, is like, is it still more risky? So for instance, if he went to, and I'm not saying that this, I'm just like, if he went to TCO.
So I think when the Rock the Johnson, everybody would do surgery on him no matter what.
Like,
Come here. Now, it is the surgeons still have to work longer to get there, but his lungs are not the same lungs as somebody who has a BMI of 45 and is all fat.
yeah.
So he works out, he has better lung, he has better heart and so on. It becomes more of a, but we are talking about for every Dwayne the Rock the Johnson, there are like 100,000 other people with that BMI that this is a statistical thing. But what this chart shows, on those people who got that surgery with higher BMI, you had to work harder, and those surgeries were more risky. Now, the red line is the MISTLF. MISTLF, you do the same surgery but with smaller opening. And what is important, that surgeon has lots of experience, more than 2,000 of those surgeries. Even in his hand, at BMI of 37, you see, it flips.
Yeah, I actually think that's kind of interesting that they even start off with a lower surgery time than the traditional one, but then eventually they get to a point where they just go, "Oh my goodness, this
So
is
that
going to
is-
take
I
us
thought
so much
that was
longer."
interesting too, especially how much more steep the red slope is.
Yeah, because then you have to work on the bottom of a smaller hole, deeper and so on. That becomes more difficult.
What are some other challenges to being obese?
But well, let's look at this. We are not done with that. Like look at the green.
Who's the
line.
green line?
We are the green.
Green's a pretty good color.
Yeah, exactly. Represent.
So that green line shows, because the way we do the surgery with the tubes, it doesn't matter if the BMI is 20 or 40. And we have done meanwhile BMI 50, 60, 64 is the highest I have done.
Wow.
Because the way we do the surgery, we are not doing the traditional surgery on the bottom of a deep hole. We use a tube system that once the tube is in place, it doesn't matter if you go through 2-inch or 6-inch of adipose fat tissue, you do perform the identical surgery. So that enables us to be very, very efficient. And that, by us being able to reduce the risk associated with the surgery, now we can provide this surgery to people who had no choice, literally no choice. Now, you know who I'm talking about, who went to the University of, here in the University of Minnesota, and the anesthesiologist was telling the patient, after the patient told anesthesiologist, "Oh, my Abbasi told me it's a 1.5-hour surgery." And they told him, "No way, this is an 8 to 12-hour surgery." Because in a traditional surgery, that would have been.
In their hands, it would have been.
In their hands, it would have been. But the way we do that surgery, actually, I did that surgery, and it was 1 hour and 6 minutes, and patient went home 2 days later and sent us all those nice letters and cards and so on, that how we changed her life and so on, because literally we changed the equation by not causing too much damage. Another thing with the longer surgery is, like, if a surgery is, let's say, 1 hour versus 8 hours, what is the surgeon doing in the other 7 hours compared to us? What do you think what the surgeon is doing?
Stressing.
himself and everybody else.
Mhm, mhm.
Being
Patient-
bullying our PAs.
Yeah.
I don't know.
Or
what
their own
else.
PA.
Or their own,
Mhm.
Well, mostly they are cutting the tissue, cooking the tissue,
Dissecting, burning.
dissecting, burning, and
Using
stopping the
suction.
bleeding.
Mm.
So obviously it makes sense that more damage to the surrounding tissue is produced, more bleeding is produced,
Mm.
more barotrauma to the lung is produced, and all of that patient has to recover from.
Gotta be poor healing too. Like,
Oh,
Well,
yeah,
yeah, let's way more. Now, one of the things we use a lot in our surgeries is called electrocautery. What is that, Dominic? Electrocautery.
so typically actually used by like Bovie device, it's an electric current goes right at the tip of it, and you use it to dissect and cauterize at the same time.
It cooks, burns the tissue, right?
Mhm.
Sometimes it smells like a fresh steak in the OR, doesn't
The
it?
grill.
Yeah, grill, yeah. But it's we need that
Mhm.
because otherwise it patient would
Bleed
bleed
everywhere.
out.
Mhm.
Okay, now having said that, all that burning of the tissue is not irrelevant to patient's recovery, right?
Mhm. Yeah, it releases smoke, and the smoke itself could be carcinogenic too.
Well, for the staff, but I'm talking about the patient that you're
Mm.
burning the tissue, all that creates inflammation
Mhm.
factors and so on, and patient has to recover from all of that burning and so on. So do we, in our surgery, do we use bipolar or Bovie?
No,
No,
actually,
we
I haven't
don't.
heard that sound in a long time.
Yeah, We don't even use a suction
Mhm.
because in a regular surgery, you put a suction and
Yep.
you like suck
Mhm.
all the
Yeah,
blood
get all the
out,
blood out.
and
Here
then
the whole
you
time
don't even
and-
use that.
Half the time you have to clamp it down so it's not annoying everybody in the OR
Yeah.
just the whole time.
He makes a better suction noise than I.
Both pretty good.
Hey, let's have it. Have a fight. Suction noise cam.
Okay. We'll have headphones.
Oh, my bad. You're welcome.
So,
I will come on my behalf.
and that is why we can give these patients these options that they don't have for a regular surgery.
Another thing that we haven't talked about that I don't know, it's like a smaller issue, but I think it's still like an adaptation that other surgeons need to adapt to is I'm assuming their devices aren't big enough. Like I'm just like I don't want to share too much info, but when we were in India, we were looking at those things and you're like, can you make it longer? Can you make it longer?
Oh yeah.
And then I
yeah.
know that we've had a patient in the past that we actually need our things to be bigger specifically to
Ooh.
That was interesting when we were in India just last week, right? 2 weeks ago. So, well, we were there and they were saying, yeah, we have these devices with a long blade, 8 centimeter, which is 2.5 inch or 3 inches, about 3.5 inch. And I was saying, no, long device for us is not 3.5 inch. It is like 15 inch,
Like
that is
3.5
10 inch.
inches, yeah.
3
What I'm saying is even if the surgeon had the skills and stuff, you would need even a different toolbox basically to treat these patients.
Well, but yeah, and we do have those different,
do, yeah.
but but the idea here is that you create a lots of damage doing in a traditional way, getting that deep. So it makes sense for lots of surgeons. They're good surgeons. They know risk versus benefit is not in favor of the patient. And they say to the patient, go lose weight and come back. Go lose 150 pounds and come back. But what's the problem with that? Why not? I mean, what's wrong with that to start with?
If you asked me to run 5 miles while I'm in agony, I would probably just hit you.
Yeah,
Right,
yeah.
I know.
That is many
Right.
of our patients say us, they say, how can I lose weight when I cannot even walk? The only thing left for me is sitting on the couch
I
and
still remember
snacking.
I still remember the story of a patient who was actually stuck inside his house and he had to crawl to his door.
Yeah, well, and
How can he lose weight?
the reality is that we see it often. They say when the surgeon, some surgeon, not everybody, some of the surgeons, they just want to get that patient out of their door. And they say, go lose 150 pounds and come back. In reality, patient goes and gain another 100 pounds, and then they die of cardiovascular problem because they cannot walk. The condition that they put more weight on. This is a deadly thing. And many of those patients, literally, they do a passive, suicide, meaning that they just let go and, they don't care anymore. They are so in pain. and they take too much pain medication and so on.
Mhm.
This is a miserable situation that unfortunately is neglected at many levels.
Yeah, it sounds like a vicious cycle of I'm overweight, my back hurts. I can't get my back to stop hurting, but I can't lose weight until my back stops hurting, but I can't get my back to stop hurting.
I don't want to keep going.
Yeah, it just goes again and again. And meanwhile, the pain gets worse, the pounds pack on. So it sounds like there's very few of us out here willing to break the cycle or able to break the cycle.
Able to break the cycle.
Able, but also kind of, in my opinion, not to be rude, but willing. Because it's 2023. I've been hearing about obesity since I was in elementary school, like learning about it and so on. So it's not like all of a sudden we woke up and half of the US was obese. You're around teaching this procedure all the time and getting shut down. I don't have time, this and that. It's your responsibility to your patient to adapt and to learn new techniques and not get left in the dust and not make these people live like that.
Well, you know, Amanda, that these patients are coming from entire US to us now.
Yeah.
And their travel, some of them, they drive days. They
Right.
cannot get in an airplane. They drive days to get to us. And they have been told by 5 surgeons they cannot have that. We do a 1.5 hour surgery, we send them home next day. We can do that. And that what unfortunately as well, it's almost cynical, sad, is that many of these patients, the surgeon says, yes, we have to balance risk versus benefit for the patient. But in many of those cases, the surgeon balance risk versus benefit to our own practice.
Yeah.
They say, is it really worth for me to try to help this patient where I know the higher risks are involved? I don't want to go answer to administration or my colleagues who and so on. So we do the safe thing. Ideally, we would be always doing the safe thing for the patient, but realistically, many of us, we do the safe thing for our own practice because we know this patient is going to gain weight, going to get the condition, going to die of a heart attack within the next 1 to 3 years, and so on. So, but at least when it happens, it is not our complication. It is safe to our practice. It takes a lots of guts, I'm telling you firsthand, to look at them and say, you know, I am willing to take that risk for you. It takes a lot of guts.
I think insurance agencies and healthcare admin need to wake up and not put it on the responsibility of the surgeon actually, and put it on their own responsibility and say, I'm going to implement these policies. We're going to be learning new procedures and can treat more patients.
Well, the insurances, many of them actually do try to do the right thing, meaning that there are codes. If somebody is that big, the surgeon and the hospital get paid more. They try to incentivize people to help them. I mean, there's like major comorbidities factors and so on. So more or less, sometimes they try to do that, but they cannot force a surgeon to do the surgery. And it all comes to the character of the surgeon itself. Now, I'm not talking about being cavalier, doing a risky surgery, but truly in our heart, we know that, you know, am I not doing that surgery because I think that is wrong risk versus benefit for the surgeon, for the patient, or am I not doing this because I have a party to attend and it's just too much of a thing to my own practice? Most of the time in our heart, we know that.
Right.
Yeah.
Well, thank you guys. I hope you learned a little bit about why your surgeon would ask you to lose weight. I'm Amanda Armagast.
Dominic Moore.
And I'm Dr. Bossi for Essence.
Have a safe weekend.